Hey everybody, welcome back to the ECG of the day. My name is Reed. If you enjoy this content, feel free to subscribe to the channel. Before we get started with this video though, go ahead and go into the description and download the PDF of today's file of this ECG so that we can follow along together. So let's go and get started. So the first thing I do is I look at the force, and the trees of my force are my QRS complexes. I like to start maybe down here at V5, and we've got a narrow rhythm that seems to be regular, and if you look throughout the whole rhythm, that narrow complex rhythm stays regular the whole way. If you look at the rate, I'll find a QRS that lands on a solid line, maybe like this one. My rate would be 300, 150, 100, 75, 60, 50, maybe 55 beats per minute. So we've got a bradycardia starting to form our differential diagnosis for what could be going on with this ECG. So we've got a narrow complex bradycardia. The narrow complex makes me think that this rhythm is at least being conducted from the AV node down through the normal His-Purkinje system for nice rapid depolarization. So something maybe associated with the AV node or higher is going on here. I see some P waves. P waves aren't so consistent, right? I don't necessarily see a P wave there. There's one, and then I don't really see one there. So we'll see what's going on. Let's evaluate those. Let's evaluate those P waves. Next thing in our step, we've got P waves that are upright in lead 1, and they are upright in AVF. So these P waves, when they are conducted, are sinus P waves. So we do have a sinus rhythm, but how is the AV node behaving? And that is our PR interval, right? And so if you notice, if I look for a PR interval, say in this first one, I'm like, this is where the P is. So that PR interval is quite long. But then we have a P right here with a shorter PR interval. And then we have a P. And we've got kind of P's marching through. What I notice is it doesn't seem like the P's are conducting to a QRS in any predictable manner, right? This one is, it doesn't make any sense that would happen. If you look at all of the links before are a lot different. And what you then start getting an eye for is that you've got P waves that are just marching through the rhythm, right? You see P, P. If you look closely within this QRS, normally the QRSs are nice and sharp, but look here, you can see this is a P wave that is buried right in that QRS, and you've got a P, you've got P. So we've got P waves that are marching through. We've got another buried P wave there, P. So we've got an atrial rate that is faster than our 55 beats per minute. If we want to figure out how fast the atria is beating, we can measure from here, 300, 150, 100, 75, somewhere between 75 and 100. So the atrial rate is, say, maybe, what do we say, between 75 and 100, maybe 80 beats per minute or so. That's much different than our 55 that we're seeing with our QRSs. And so I don't see that these P waves have any relationship with the QRS. And so if there's no relationship with the QRS, our atrial rate is fixed and it's faster than the ventricular rate, then this is pretty good criteria for a complete AV block or a third degree AV block, right? Complete heart block. The AV node is not conducting any of that signal down. And so in this case, we have this regular QRS that is beating and likely is an escape beat, right? Because if this AV node is completely blocked, well, how is the QRS going to form? It's going to form from an escape focus within the His fibers that ideally send signals down our His-Purkinje system. We still get rapid QRS depolarization, but we know that the kind of Hisian junctional beat usually occurs at 40 to 60 beats per minute, which is exactly in line with what we see. So it's behaving exactly how we should expect. Let's evaluate that junctional rhythm. We can still evaluate the QRS. We see we've got upright QRS in lead 1. We've got an upright QRS in AVF. Tells me my QRS axis is going down and to the left, which is normal. That's great. And I've got maybe some early transition with my R waves here, V2, V3. Kind of hard to say if that means anything, if it's lead placement or not. And we've got a narrow rhythm, like we said. So yeah, this makes sense that this is a junctional escape rhythm. So we've got a junctional escape rhythm at 55 beats per minute. And then we can still look for pathological Q waves and ST changes throughout. And I don't see any pathological Q waves that make me think of a prior infarction that really kind of stands out in any sense. And I don't see any ST or T wave changes to indicate this could be an infarction, right? We know that our AV node, if it is blocked, it could be due to maybe, we know the right coronary artery supplies the AV node. And so sometimes you'll see in a right coronary artery infarction, there will also be a complete AV block as well. And so that's kind of a nice little correlation there. So you would see in that case inferior ST changes, but if you look in the inferior leads here, I don't see any inferior ST changes. So likely not the case. And let's put that all together. So what do we get? We've got a sinus rhythm with a complete AV node block. In conjunction with that complete AV node block, our escape rhythm is junctional in nature, and that junctional escape rhythm is beating at 55 beats per minute. So hope this helps. This patient would benefit really well from a pacemaker. You can have pacemakers that they have leads that are in the right atria and leads that are in the right ventricle, right? And so because this person seems to have a good sinus node, right? Their sinus node is just beating away, right? It's just beating. We see nice P waves, sinus P waves. We know that really we need to get the ventricles to sync with our atria. And so you can stick a wire in the atria that could sense when the atria fires, and then that pacemaker can tell the ventricles to fire just a few seconds later, or a few milliseconds later, we'll say. And that can synchronize them and have much better cardiac function for these folks. So I hope this helps. If you have any questions, throw them in the comments. Feel free to like and subscribe to support the channel, like I said, and see you tomorrow. Have a great day.